be discussing an approach to urinary incontinence. So I think Dr. Billy Magagula has done an introduction, so I don't have to go through that again. So our learning objectives for today, we'll look at the definition of what urinary incontinence is, the epidemiology, different types of urinary incontinence, and a basic workup or how to work up these patients that are having urinary incontinence, right? And we'll also conclude by looking at the basic treatment that entails in terms of treating these patients that are having urinary incontinence. So by definition, what is urinary incontinence? So according to the International Continence Society, urinary incontinence is defined as the loss of involuntary loss of urine. So that's how they define it according to the international standards. So there are other issues that are actually associated with urinary incontinence. We know it severely impacts on quality of life of women. So whereby it's affecting their psychological health, their social function, their body image, and their overall well-being. And then this actually even perpetuates in terms of affecting also their quality of life in many ways, including personal relationship and physical limitation, be at work or be at home, their marital or their marriage can be actually affected by this condition. So when we look at the epidemiology, it's very common in women compared to men. When we look at the prevalence globally or in the European countries, it's mentioned that it's about 15 to 40%. And then in the US, approximately 40% of women in the US are having urinary incontinence. And however, globally it's reported that it's actually less common in black women and Asian, and more common in whites. So in the South African context, we actually don't have data when we look at the South African context. There hasn't been proper studies conducted. So what we see or what we can quantify is from the community-based studies, whereby they actually identified between 16 and 67% of patients with urinary incontinence. And those physician-based studies whereby they are able to identify, or probably we have about 0.5 to 5% of patients with urinary incontinence. And the reason being is because the reason why we in South Africa, we are not sure of what is happening, I think it's because of underdiagnosis or underreporting, or maybe treating it as if it's just a simple UTI. So basically, that's the reason why we actually don't have proper data in South Africa. So how does the urinary bladder work? So I didn't go into much scientific details on how it works in terms of the pontine maturation sector and all that. So, but what we look at, we know that it's a hollow organ. So its main function is to fill and then to store the urine. And afterwards, when it's socially acceptable, you're supposed to sort of urinate, right? So the neurological supply of the bladder is very complex. So I didn't go into much details, but you must just know that it's got a detrusor muscle, of which is what works when the bladder is full. So there are some receptors around the muscle, the detrusor muscle. So they will send signals to the sacral nerves. Then they communicate with the brain, and then they will tell when it's socially acceptable, you need to go and urinate, right? And then of course, then there's a function of the internal urethral sphincter which will be relaxed, and also the external urethral sphincter which will be relaxed, and you're able to pee normally. So what happens is that this bladder, it can hold up to 1 liter of urine, but the normal capacity ranges between 300 and 750 mils, right? But it can hold up to 1 liter of urine. So going back to our topic of interest, so there are different types of urinary incontinence, right? So we've got stress, we've got edge, we've got mixed, and we've got overflow. So stress is just an involuntary loss of urine associated with effort or physical exertion, right? And then we've got edge urinary incontinence, also referred to as overactive bladder, right? So this one is it's an involuntary loss of urine associated with agency, a sudden compelling desire to pass urine. That is difficult to defer. That one you cannot say, you cannot decide otherwise. Once you have urge, you need to go to the bathroom. Some patients, they don't even reach to the bathroom, right? And we've got mixed. Mixed, as the word says, is a combination of stress and urge, right? And then we've got overflow incontinence. So overflow, what happens is that typically those patients, they present with continuous urinary leakage or dribbling, the setting of incomplete bladder emptying. So usually they've got, either they've got neurogenic bladder, or they've got detrusor underactivity, or they've got some bladder outlet obstruction of some sort, right? So basically these are the different types. And then there's another one that I actually didn't put into details, which is called functional. So functional incontinence or urinary incontinence, we find that in those patients that they've got some form of physical disability, be it maybe they're on the wheelchair, or so when they can feel that they want to pee or they want to go to the bathroom, but because of they're incapacitated, they're unable to actually do so, of which is something that actually burdens the caregivers for those patients. So those are the ones that have functional urinary incontinence, right? So what is the etiology for we'll look at them in different, we'll look at the stress and we'll look at the agency later on. So stress urinary incontinence has got some few risk factors or etiological factors that can actually contribute to one having urinary incontinence. So it's common across all age groups. So majority of them we find them in the elderly, like your 40s, 50s, and 60s. However, there are some there's literature, or even in the clinical practice, you'll actually find that even around the 20s, you'll find patients presenting with urinary incontinence, right? So childbirth is one of the risk factors that contributes to urinary incontinence. And about 67% of cases of urinary incontinence is because of childbirth, And it's been shown in literature that actually when you have had a Caesar or cesarean section has less risk compared to normal birth, but doesn't completely, delivering by cesarean section doesn't actually completely eliminate the risk of having urinary incontinence. Obesity is a problem. So we know the lifestyle that we are actually living nowadays, McDonald's or whatever, and then we are just obese. We are just an obese society. So that's a risk factor for urinary incontinence. Heavyweight bearing. So nowadays we find that in the midst of this obesity, people are also going to the gym. You're very active. They're lifting weights and so forth to look good. So it can actually contribute to urinary incontinence as well. Patients that have had removal of their womb or hysterectomy, age, it's a factor. I think I've mentioned the age earlier on. Menopause, smoking. The reason why smoking is a risk factor because usually people that smoke, they have this chronic cough. So of which it's actually increase your intra-abdominal pressure. Then you end up having urinary incontinence. So basically that's what will happen. So you've got this increased intra-abdominal pressure by different factors, being cough, sneezing, lifting heavy objects, or laughing or exercising, of which they can actually lead to urinary incontinence, right? Mainly the stress. My slides are not moving. Okay, so I've got now we'll look at what the etiology of what you call the edge urinary incontinence, right? So with this particular entity, it's very difficult to see what the problem is because majority of them, 90% of them, they are idiopathic, right? So because of the urinary incontinence, so about 10% will have edge, right? Of all the patients that are having urinary incontinence, majority of them is stress, and minorities about 10%. About 10% it's from will have edge urinary incontinence, and of that 10%, 90% of those patients you don't even know what's the problem, right? So they could be having some detrusor muscle instability, they could have blood outlet obstruction, they could have central nervous system lesions, cystitis, could be interstitial cystitis, could be chronic cystitis, increasing in age. Obesity again appears, obesity is usually a problem, right? And then there are other diseases that can actually predispose one of having what do you call urinary incontinence or edge urinary incontinence. So there's some brain lesion, there's some spinal cord lesion, and some peripheral nerve that could be injured, and that can result in edge urinary incontinence, right? So CVS, patient with stroke, patients with TBI, demented patient with cerebral palsy, Parkinson's disease, multiple sclerosis, diabetes mellitus, Guillain-Barré syndrome. I think we've mentioned labor as well, traumatic labor, So these are some of the risk factors that can actually contribute to a patient presenting with edge or overactive bladder, right? I don't know, people are raising hands here. I don't know if I should stop or should wait, I'm not sure.
No, continue, Doc, thanks. Don't
Okay.
forget the hands, thanks.
Okay, and then what are the clinical features of edge urinary incontinence? So mainly this case or this patient's it's loss of urine, like when they actually have the urge to urinate. So what will they present with? They've got urgency, they've got frequency, and sometimes they actually have to wake up in the middle of the night to sleep, which is called nocturia. So nocturia, mainly, you're not supposed to wake up, at least if you have to wake up at night, should be only once. But if it's more than one, in one episode that you have to go to the bathroom at night to pee or to urinate, so that's actually nocturia. So it should be actually investigated, or why is that happening? Because it's not physiological, right? So, and what is it that this agency do to these patients with overactive bladder? So they've got increased frequency, right? Because they are scared of having agency. So they will go to the bathroom even though they are not having any urine in their bladder, but because of they are scared of having agency, so they will want to urinate more frequent than usual, right? And then it makes them to behave in a certain way, or to adapt to their condition, of which by themselves they will want to restrict fluid taking. They know in their workplace or wherever, or even in malls that they usually visit, they actually know where the toilets are. They map the toilet so that at least when they are stressed, they know where to go, right? I think I've mentioned that they intentionally increase their frequency. And of course, they restrict some of the activities that they will want to engage in because of their agency, right? So as a clinician, this is what we need to do, because we need to evaluate these patients when they come to our practices, So you want to understand for these symptoms, how long the duration of their symptoms, how often do you actually leak? Once a week, twice a week, because this is very important when you have to manage this patient, because especially patients that are having edge incontinence, those patients you actually want to improve their quality of life, so you won't be able to completely cure them. So it's actually about improvement of the condition, right? So how often do they use the PET? They use PET daily, and how severe is it? Have they stopped going out? Has it affected their quality of life? Are they now in depression? They stopped running, they stopped hiking, and so forth, and all that, right? Then we want to know the amount of urine that is urinated, right? So whether it's small drips or is it large gushes? Do they just use a small panty liner, or they have to use diapers now? So you should be able to quantify the amount of leakage that is there, right? And then the other thing is you need to understand whether they make it on time to the bathroom or not. So, because you saw that you are able to understand what's happening with this patient, and then how will you be able to improve their symptoms and their quality of life, right? So there are other important aspects of history that we should not forget about, right? So obstetric history is very important. So from the obstetric history, it's important to take their parity, and then during birth, if they had normal birth, was there any use of instrumental delivery, vacuum extraction, or use of forceps? So those are things that we want to pick up from that. From gynecological history, You want to know if they've had maybe they're screened for fibroids, or they've got pelvic masses, or they've had hysterectomy before. So those are the things that you want to actually look at. And the sexual history is also important here, because there's a condition called, or there's an entity, or whatever you can call it, coital incontinence, right? Which is something that happens during intercourse, which can lead, which is a sexual dysfunction, right? And we shouldn't confuse it with orgasm, squirting, and so forth. So I think it's important that you understand should be able to differentiate the two. Take a proper medical history, right? So check if this patient is not on any diabetic medication or diabetic treatment, or antidepressant, the drugs that they are taking. Are they taking diuretics? So those are the very important things that you need to pick up from history, right? Surgical history is important to take as well as social history. Surgical history, includes if they had hysterectomies or not, right? Social history as well is important, right? So on examination, these patients, when they come to our practices, we need to examine them, right? General examination is very important. Do a quick neurologic exam with an assessment of sensory and motor function. It's very important, because remember when we were alluding to the causes of overactive bladder or edge urinary incontinence, it was mainly around the brain, the spinal cord, peripheral nerves. So it's important to do your neurological assessment, right? And the most important one is your pelvic floor examination. So with your pelvic floor examination, you need to look at the vaginal walls, you need to look at the perineum, you need to assess the external anal sphincter, assess for the support, the sensation, look whether there's atrophy or not, right? Whether there's evidence of pelvic organ prolapse, especially those patients that have procedentia or stage 3, stage 4 pelvic organ prolapse. Because sometimes those patients, they have got what we call occult stress urinary incontinence. So once you repair the prolapse, you discover that later on, these patients are having stress urinary incontinence. So those are the things that you need to evaluate. Check if they've got pelvic masses. Pelvic masses, compression of the bladder, irritating the detrusor muscle, resulting in edge incontinence, right? Check if this pelvic floor is able to contract properly, right? So those are the things that you need to assess, right? Then during your examination, you should be able to actually do a Valsalva maneuver. It's better than in standing position, so that you can be able to elicit the stress incontinence, right? So the cough stress test, better than standing and supine, so that you are able to actually, or even if they are just jumping in the consulting room, you'll be able to elicit if there's any leakage of the urine or not, right? So what is the basic workup that we will do for this patient, right? So the basic thing that you do is the urine. If you're in your practice, you can do a simple basic urine dipstick, right? Then you'll be able to see. And then if you pick up maybe the leukocytes or the nitrites, then you should send it to the lab for culture and all that, so that you can exclude urinary tract infections, because they can present as agency as well, right? Or frequency agency. They will actually give you the lower urinary tract symptoms, right? So bladder diary is very important. You want to diarise, we want to actually have a clear overview of what's happening to their bladder, right? Screen for diabetes. We'll actually chat later on about bladder diary. Screen for diabetes, right? Because we know diabetic patients, they have a tendency of frequent urination, right? And then the other test that we should actually also do is a post-void residual volume measurement, right? This is usually not recommended at the GP practice. Usually it's better because usually we do it when things are tough, like you failed with your basic treatment, then you want to actually do sort of urodynamic studies, then you'll do the post-void residual volume to understand what's actually happening, the functionality of this bladder, So the other special investigations that are important is your urodynamic studies with or without EMG, which is electromyography. You can actually assess urethral pressure profiles. And then what is important again is we can do the transperineal ultrasound. So those are actually specialized investigations. They're usually done in higher centers like academic, like our Urogyn unit. We are actually equipped to do all these studies. And earlier on, I did mention about the bladder diary. So what is it that is going to assist us with this bladder diary? When you go through the literature, they will recommend that it's better to do it the 3-day profile or 3-day profiling of the urine. But over 24, it's been shown latestly or recently that a 24-hour quantification will be able to give you the result of actually what's happening to this bladder, right? And then we use them to initially assess this patient that have urinary incontinence or overactive bladder, right? So yeah, they help us to assess the symptoms and their severity. And of course, later on, once you have initiated treatment, you'll be able to actually see whether your treatment is effective or not, or you need to escalate to other treatment modalities. So what are the basic management of urinary incontinence? So I think I did mention earlier, it's important to understand what's wrong with the patient goals and the desires. So by so doing, you'll be able to offer appropriate treatment. So if you don't have an understanding of where you are going with your patient, it will be very difficult to offer the best treatment modality, because you've got patients that will say, Dr. I just want to go to theater straight away. Or some will say, no, let's start with basic, management or a non-invasive approach, right? So in terms of categories of treatment that we have, so we've got behavioral or conservative management, we've got medical or pharmacological management, and of course, we've got surgical management. There are other management options that I will also allude to. So in terms of behavioral or conservative management, we've got lifestyle modification options that we should focus on, right? So patients should actually avoid irritants. Yeah? So caffeine, donuts, or sweeteners, right? So what happens is that stopping coffee will not completely eliminate the overactive bladder, but it will make it better, or the urinary incontinence, it will make it better, So we know our patients, they love drinking coffee, they like doing so. So maybe the advice will be stop if possible, but if not, maybe reduce the number of cup of coffees that you take on a regular basis, right? Fluid intake scheduling might actually help, So avoiding, let's say maybe this patient is suffering from severe nocturia, or maybe they wake up about 3-4 times a night. They shouldn't take fluids before they go to bed, or they should have their supper earlier than scheduled, or like earlier than maybe 9 o'clock, 10 o'clock, because they are going to have to go to the bathroom now and then, Timed voids. They can actually have a color or a timetable. Okay, I need to go to the bathroom, especially those ones that have urgent incontinence. Okay, I need to go to the bathroom at this particular time so that I can make sure that my bladder is empty and I don't have this incontinence, to reduce the number of incontinent episodes. Weight loss is very important because we know obesity affects both urinary incontinence and urgent incontinence. We saw that obesity is one of the risk factors, right? Bladder training is important. Pelvic floor exercises, the Kegel exercises, physio alone, it has shown to improve those patients with the symptoms of urinary incontinence by about 50%, right? Biofeedback mechanisms, vaginal inserts like pessaries, especially a rim pessary that is demonstrated on the slide there with a knob, actually helps better to actually angulate, especially those patients that have stress incontinence, because it's an issue of pelvic support. So you want to just support them so that they're able to control their, or to be continent. So there are some epidemiological studies that have been done that actually shows that weight loss is very effective in reducing the urinary incontinence in women, right? So both surgically or otherwise, it's effective reducing urinary incontinence symptoms and should be strongly considered as the first line treatment for overweight and obese women with urinary incontinence, right? So moving on to pharmacotherapy, estrogen has been described as one of the first line treatment that we can actually use. However, we know that in our country now recently, the estrogen vaginal cream, Premarin vaginal cream is sort of discontinued. However, we can actually use Vagifem. It's vaginal tablets. They actually work well, and there's good response from patients regarding that. They are alpha agonists, of which are pseudoephedrine. They usually stimulate the urethral smooth muscle contractions, and then it's able to actually improve symptoms. And there's an antidepressant, duloxetine as well, that actually works. It's an antidepressant approved by the FDA for the usage of stress urinary incontinence. And then from the Cochrane database, it has shown that it has minor improvement in quality of life and incontinence episode. However, there are issues with the side effects. So when you go through literature, it suggested that most of the patients, they had nausea, and they discontinued this medication. And it actually even had exacerbated their mental health issues because they had suicidal ideation and all that. So what are the issues here? So maybe it can be an option for those patients that are unfit for surgery for whatever reason. Maybe they're elderly or they're not fit for surgery. So then you can actually consider giving them duloxetine. And then with overactive bladder, it's a very tricky disease to manage. So I think I did mention earlier on, it's all about improvement and then there's no cure, right? So first line treatment will be your anticholinergic drugs. They take about 3 to 4 weeks to work, you know. So you've got a non-selective option, which is your oxybutynin or ditropin. So you can start with a low dose, 2.5 milligram BD. You can go up to 5 milligram 3 times a day. So how does it work? It just interferes with the postsynaptic receptors to block the action potential and prevent muscular contraction, right? So it's more effective in decreasing the urinary incontinence episode, and is the mainstay of treatment if non-drug approach fails, especially in the government sector. We do have it in the government sector. What are the issues? The issues are the side effects, and the compliance is an issue because the side effects are actually bad. So those patients, they will have dry mouth, constipation, urinary retention, and usually this will lead to poor compliance and discontinuation of medication. Right? So, however, and also must have in mind with on those patients that are having closed angle glaucoma, or that have gastroparesis, or some issues with the gastrointestinal system. So must be careful when you are prescribing such or anticholinergic therapy. However, there are other newer drugs of which they have better side effects profile, or they're more tolerated by patients. So one is Vesicare. I think it's used widely in our country or here in the GP practices. You find that, you know, we prescribe them daily in patients that are having agency with urinary tract infections, of which patients, they tolerate it very well, right? And the other option would be your mirabegron. Is a newer drug. It's selective beta-3 agonist. So how it works, it relaxes the diffuser muscle and facilitates storage of the urine. So the studies have shown that it improves quality of life and it reduces incontinence episode, and it's got less side effects. However, we must be careful in those patients that are having hypertension because it can actually elevate your blood pressure. So it's very important to just have that in mind when you are prescribing mirabegron. So what are the other procedures that we can look at, you know? So there are other options like bulking agents. So these are the patients that are having stress incontinence, right? So you can offer them bulking agents. So as a first line, you know, before you become more invasive by doing a batch procedure or putting a sling. So Bulking agent is just an injection of some bulking agent around the urethra. So OFH, it does help, it does improve incontinence. So I remember we had a patient who had, I think it's 38-year-old, very young patient. We took to theater in Feb for bulking. The bulking procedure went very well, it was successful. However, it only improved her symptoms for like 2 weeks. And then I think last month, sometime in March, we took her back to theater to do a transobturator tape insertion, which is a sling procedure. After that procedure, she was actually cured of her stress urinary incontinence. So that's why in the literature it's actually reported to have 90% cure rate. So slings are one of those options. Batch procedure, the efficacy is similar to the sling. You can approach it depending on your skill. So this will be patients that are now referred to a higher center. So you're not expecting it to be done unless if you are experienced at primary healthcare or secondary healthcare. So you should be able to know how to do these procedures. So you can approach it either laparoscopically or open surgery. So what you want to do, you just want to strengthen the pubourethral ligaments so that at least the continence mechanism is sort of brought back to its normal function, right? So there are other treatment options that have been shown to sort of work, vaginal laser therapy, gynolase, this gynolase, they use it for all sorts of things. So for vaginal rejuvenation, patients that are having vaginal atrophy. So it works for those type of patients, right? So it has also shown to actually work in patients that are having urinary incontinence, especially stress urinary incontinence, right? And the latest that is still under investigation, they're just newer studies that have been done. The numbers are still low. So whereby they're using the autologous like platelet-rich plasma therapy, which is where they take patients' own blood, they separate platelets, and then those platelets, they inject in the posterior vaginal or anterior vaginal wall. So what does it do? It helps with the tissue regeneration and neoangiogenesis, right? But whereby it will be promoting vascular ingrowth and fibroblast proliferation, right? So, so by so doing, it actually reinforces the pelvic floor again, so that at least those patients can actually improve, especially the patient with stress urinary incontinence. It actually shown to show some level of improvement, but there's still a new thing. There are still studies that have been done regarding the platelet-rich plasma. So there are other advanced therapy for EDGE or the overactive bladder, which is Botox, just the Botox injection. So this picture that is shown on that slide, so it usually shows where you will inject this botulinum toxin. So it's very effective as well. It lasts up to 9 months. So it's something that it's an option. Also sacral neuromodulation and tibial nerve stimulation or percutaneous stimulation of the tibial nerve, of which there's are advanced therapies that are done in advanced like tertiary centers. So that can actually help patients that are having overactive bladder, especially that they have failed conservative management, you have failed medical management. And that's when we'll be able to actually refer those patients for these advanced therapies, right? So when to refer to a subspecialist, will it be the urologist or urogynecologist? Patients with incontinence with abdominal pelvic mass, or they are having hematuria in the absence of UTI, suspected vesicovaginal fistula. So you want to look at this patient that are having vesicovaginal fistula. The other day we had a tutorial with Dr. Van Wyk at the University of Pretoria, Steve Biko there. There was a story that was actually very sad. It's a patient from Pumalanga, somewhere in Pumalanga, who gave birth 20 years ago. Yeah, her child is 20 years. Then 20 years ago, she had a birth whereby she had prolonged second stage. They took her for a cesarean section. And afterwards, she developed vesicovaginal fistula. She was taken from pillar to post. Now, imagine for 20 years, this patient has been seeing doctors, nurses, or other healthcare professionals, but she never managed to actually get help, whereby she was supposed to have been seen, okay, this patient is leaking. This patient is using pads every single day, there's something going on here. So she was referred to urology unit, and they actually fixed this vesicovaginal fistula. Now, the quality of life is better. So in the future, you see patient like this, just refer to a subspecialist. Patient with pelvic organ prolapse, I think I did mention earlier on, this patient sometimes they might have occult stress urinary incontinence. Please refer them to a specialist, right, or to a subspecialist. And then, of course, if maybe we are giving treatment, you realize this patient suddenly developing avoiding dysfunction, not avoiding dysfunction, spelling error there. So they're having voiding dysfunction from drugs, or they're having urinary retention. So those patients, you need to actually refer them to a subspecialist, right? So in conclusion, urinary incontinence is very common. Unfortunately, in our setting is underreported or underdiagnosed. Hopefully, platforms like this will raise awareness that there's a condition called urinary incontinence, and us as healthcare professionals will start asking questions so that we can actually pick this patient up so that they can get assistance. Us as practitioners, we should make it a norm to screen for this patient that are having, or to screen for urinary incontinence, like we screen for cervical cancer and so forth. And then complex cases should be actually referred to a subspecialist, be it a urologist or urogynecologist. Oh, thank you.
Yes, thank you very much, Dr. Molefi. I think that was quite insightful, and really you have given a lot of clarity around quite a number of issues that we generally have. Maybe before, I want to check in the audience if we do have a physiotherapist, because I think you raised a number of interventions that maybe are linked to someone needing some exercises or physio as an intervention, but also to check if there is a urologist as well who might be attending. Yes, I see there is Seketani, so Holele. So let me see if I can find you and allow you to talk. I know I'm putting you on spot, but if you can just unmute and give us some tips around physio, the role of physio, and what is usually done in the context of urinary incontinence. Yes, you may unmute. Thank you, Faith.
Hello, everyone. Thanks for giving me this opportunity to share the knowledge of the role of physiotherapy in urinary incontinence. Yes, indeed. A lot of patients have improved, as the statistics have shown that 50% of the patient do attend physiotherapy as a consecutive management of urinary incontinence have got improvement. What we basically do is take a history, as he have alluded, and then we have got the exercises specifically for the certain muscles within the pelvic floor muscles which are more affected. And a lot of exercises that have been mentioned as to how to contain their urine and how to make sure that they remain physically active, because physical activity has also been found to help in urinary incontinence. So in cases where they have got urinary incontinence, sometimes we have got the Kegel balls. However, in rural communities, would advocate for other means of exercises to help with urinary incontinence. Thank you.
Just Faith, on that last comment, because I think the person who was asking about the exercises is probably a primary care professional, where access to physio is always a referral away. In a very basic level, what do they tell the patient to do? I don't know if it's possible to explain that virtually.
Virtually, it's, you know, the exercises, they're not really specific, as you have alluded that there are several types of types of urinary incontinence. For example, the exercises that I will give for someone with edge incontinence are different to the exercises that I'll give to someone with stress incontinence. So as he have already explained that there are several types. So even with the exercises, we have to be specific to the type of the urinary incontinence that the patient is having. We can teach the hold, relax exercises. However, with the age, you might find that instead of bringing more, it even worsens the situation. So truly speaking, with the type of exercises, it depends on the type of the urinary incontinence that one might be having.
Great. No, thank you. Thank you for that. Also, if there is a urologist, please do raise your hand or type there so that we can give you a chance to talk about the interface between urogyne and urology and how do we then get the best care for our clients. Dr. Magagula, are you there? Maybe you have noted some of the questions because I see they are coming in the Q&A there. Maybe let me give you a few minutes to go through some of those. Thanks.
Thanks, Alex. Thanks, Aaron. It was a great and very insightful presentation. As expected, you know, you've done justice to the talk. So well done. Thank you so much. I think maybe to follow up on the question of exercises, there's a question where they are asking about bladder training. How do we advise or what is it that we mean by bladder training? I think this is probably a question on one of the slides where we talk about edge, whether it's an edge with incontinence or just edge, and it's basically no leakage. I don't know if you want to say a word on that, Dr. Molefi, and maybe one of the physios as well. I see there's a couple in the chat there.
Yeah, maybe I can give you an opportunity to one of the physios because mainly it's physiotherapy, it's like bladder training. So basically, let's say the patient who has got an edge, mainly with edge incontinence. So you can feel that the urine wants to come out. So what you it's an issue. It's a question of brain connecting with your bladder. So you must be able to control it. So you teach it. Can use this bladder must stop now. Then you try to see if you can. It's like maybe to make it a bit odd. No, let me not make it that odd. You just tell your bladder, can you stop for now? Then you'll see the edge will sort of subside a bit. Then you're able to go to the bathroom. Then when you are ready, then you can actually pee. But it's mainly an exercise that is done by physios. So maybe if one of the physios is familiar with that, they can actually elaborate more on that. So it's an issue of bladder control, you know. So you tell your bladder, no, you can't. I can't let you now. You can't let the urine pass now. So it's not the right time. It's socially not acceptable. Then you can actually wait up until the environment is conducive for one to actually urinate.
So it's basically more like spreading the time frames or the periods between voiding episodes. To say if
Yeah.
maybe I pee every 30 minutes, I try to expand it by what, 45 minutes to an hour or more, something of that sort.
Yeah, something of that. You train, or okay, I have to pee at 6, at 7:15, at 8:30, you know, at 9:45. So sort of something of that nature.
Awesome.
Yeah, I'm seeing Pindi, the physio there. She's got her hand up. Pindi, you want to give us advice? Thank you.
Oh, yeah. So, yeah, Doc is right. I think it's all in the mind game. But most of the exercises that we do is called the bridging exercise, where you lie in crook lying and you hold and release. It's basically also a lot of awareness brought to the ladies, especially when you're driving, when you're sitting, to always keep tight on your vaginal and your bladder systems. That's more the retraining of the bladder in terms of the stress incontinent issues. And then if there are underlying conditions, then you would further investigate. But the baseline will be that contract of your vagina, just to retrain the muscles and the systems. That this is how I retrain the holding systems and the releasing system. And most importantly, if you have issues of overflow, you do that while you're peeing. So we encourage a lot of fluid intake, and then the most you go in the toilet, that's where you then train. You hold it for a couple of seconds or counts, and then you release it, which is basically that's the training. Thank you.
Thank you for that. Magagula, before we continue, I see a little bit more hands. And Ndivuo, do you want to make a comment, Ndivuo, or ask a question? Ndivuo?
Am I in?
Yes, you might have a little bit of bad network, but yes, you may continue.
Yes, I'm also a physiotherapist,
Okay.
currently working at Steve Biko also. So that, yeah, with our approach is mainly when we get a referral with a patient presenting with incontinence, the first thing that is very important with us is to assess the muscle or the pelvic floor muscle. Because normally we use the normal muscle grading, where like an Oxford grading scale, where you have a grade 0 muscle power, grade 1, grade 2, up to grade 5. So for a physiotherapist to know when to start with the Kegel exercises, first thing you need to know the muscle strength of the patient, because it will be unfair for me to if a patient comes to a practice or to receive my services and just teach them the pelvic floor exercises without me having the baseline of the muscle strength of a patient. So after assessing the patient, I will know if the patient has a grade 0 muscle power, then I will know that there are electrical stimulations that we use to try and boost the muscle until we reach to a desired effect, of which is about grade 3 muscle power. So if I know that my patient is a grade 3 muscle or grade 3 pelvic floor, that's when I know I can really try and start teaching my patient how to actually do the Kegel or the pelvic floor muscle exercises. So like the doctor during the presentation, he mentioned that examination is very important. For me to be able to manage my patient properly, I need to know where I'm starting and then where will be my aim with the treatment. So assessment is very important for me to know my baseline with the treatment. Thank you.
Yes, thank you for that. I saw a comment from Busisiwe Jele. You are talking about urinary incontinence following radiotherapy. I've given you talking rights. I don't know if you want to summarize your scenario so that we can engage with it. Busisiwe, you may unmute if you can. Busisiwe Jele, you may unmute. Otherwise, if you are unable to unmute, Doc, there was a case, a comment by Busisiwe Jele. She's talking about a patient who's got more than 3 predisposing factors, who went for a hysterectomy and is now undergoing radiotherapy. And the question is, what are the possibilities for improving this type of a patient's urinary incontinence post-radiotherapy in terms of some of the treatment modalities that you have mentioned? Thanks.
Okay.
So sorry, I missed the part. What does the patient have? She's got incontinence, and what are the other factors? I missed
So
that
it's
part.
got 3 predisposing factors: normal vaginal deliveries. She's postmenopausal, obesity, currently hysterectomy due to cancer, and she's got now urinary incontinence post hysterectomy and radiotherapy. So what are the chances of her urinary incompetence improving and so on? Yeah.
Now with that patient, I think she needs to be assessed to understand or which aspect of urinary incontinence does she have, because she has had a hysterectomy, you know. So is it stress, or is it she has had radiotherapy? Is it does she have a vesicovaginal fistula, you know? So those are the things that need to be assessed, check, or what actually is wrong with this. What type of urinary incontinence does she have? I think it goes back to taking history, understanding, doing a proper examination to check what type of incontinence does this patient have. Because usually patients that have had radiation, you know, they've got issues with chronic cystitis, you know, of which can be more of agency, overactive bladder, kind of like of presentation, right? Or radiotherapy can also post-hysterectomy, VVF, vesicovaginal fistula, overflow incontinence. So those are the issues that we need to understand what's wrong with the patient so that we can offer the best possible treatment, you know.
No, that's cool. And Tembela, I think it was when you presenting, he's like, oh, doc, for interest's sake, how actually do we measure post-residual volume? Is it something that's done by specialists only, or can this be done as well at the district level hospital?
Oh no, post-void residual volume, it can be measured. Usually you need a patient to, let's say for instance, you are checking whether the patient has got stress or not. So the patient has to have a bit of urine in the bladder, right? Then you do your Valsalva maneuver, and then you'll be able to elicit stress, right? Then after that, you'll ask them to empty their bladder. They go to the bathroom. Then when they come back, or you can actually even, when they come back, then what you do, especially when you are doing your urodynamics. So we do what we call a uroflow. So after uroflow, then before you start doing the actually cystometry and all that, you'll want to check how much urine was left. So you catheterize, then you measure what is left there. It's an easy way. Or you can actually use a transperineal ultrasound. So whereby you'll be able to do some multiplication there on whatever the urine that is left in the bladder. Then you'll be able to, there's a formula that you use to measure using an ultrasound when you're checking the bladder. Then you're able to actually check how to calculate the residual volume. In the normal one, we don't want them to have above 150. You know, it's abnormal. You know, I see Dr. Morasa.
Yes,
he's a urologist. Maybe we can, for the time, I know the time is not on our side, maybe we can allow him to say something.
Yes, I've given him the audio rights. Doc, you may give us your commentary, advice, and also answer the interface between urogyne and urology. Thank you.
Yeah, thank you very much, everyone, and thank you very much for Dr. Murifi for the excellent talk. We know that urinary incontinence, whether in female, males, or even in children, is actually a complex entity. Is a complex in a sense that sometimes we investigate these patients and we don't really find out, especially overactive bladder or urinary incontinence, what you call edge urinary incontinence. You investigate them, still you don't find the cause of incontinence. So I think he did justice in the talk. You know, he made it was a great overview. So just to come to I was listening to some of the questions that were asked. There was one that was very interesting. I think someone from, I don't know if it's Steve Biko, asking about a complex patient that had hysterectomy, radiation, and all that. And Dr. Mliff alluded very well there that we need to find out what is this urinary incontinence? Is it overactive bladder and kind of urinary incontinence? Is it edge urinary incontinence? Is it stress urinary incontinence? Because that then will determine, the way forward with this patient. And remember, patient can present with other type of urinary incontinence that you did not mention because of time. We're talking here about paradoxical urinary incontinence. So this is a patient, usually is a patient that has hysterectomy, like the patient that was mentioned. This patient still has got the overflow bladder. So the urine comes out all the time. At the same time, the patient can feel the bladder filling and go to the bathroom, because usually it's because when they were doing the hysterectomy, they injured one ureter. So one ureter is leaking into the vagina, coming out from there. The other one is going into the bladder. So the other one makes the patient to look like everything is normal, while the other one is a continuous flow. So we must be careful of that, what you call as a paradoxical urinary incontinence. So yeah, there's a couple of things. And again, if a patient has radiation and has got VVF or has got the ureterovaginal fistula, we wait because the tissue is friable. So that patient usually wait a minimum of 3 months, sometimes 6 months, depending on what kind of radiation the patient had, other comorbidities and so forth. Yeah, I think overall, again, the last question that was asked about how do you then measure post-void residual? It's a very easy thing to measure. You ask the patient to go to the bathroom to pass urine, and after that you pass a catheter. Whatever that remaining, there's post-void residual. Like I said, we say it's clinical significant if it's above 150 mils. If it's less than that, then we can actually quantify that. There's a way of quantifying it. There's 1, 2, and grade 1, 2, and 3. This is less than 50, 50 to 100, 100 to 150, and above 150. So if it's above 150, it's clinical significant. You need to investigate and check what is really happening. That's one way of measuring post-void residual. The other one is the one of ultrasound, which is also very easy. You ask the patient to pass urine, and then you go and measure. You just need 3 measurements, and then you've got your answer. The other one is using urodynamic study, which is more complex. So even someone that is at level 1, service can actually measure post-void residual. But I think overall, everything was said in the presentation. Like I said, it's quite complex, and it actually mentioned most of the things that are important.
Yeah, whilst you are still here, maybe the two of you can respond to 2 things. So in terms of referrals, how do we know who to refer to? Do we, is there a clear line between urogyne and urology? And maybe, yeah, let's respond to that. And then there's another question from one of the colleagues, and then maybe we'll see how far we go with time. Yeah.
I think it will more depend on the gender. If it's a female, it becomes more complex. But if it's a male, it's obvious. If it's a child, it's usually obvious. So if it's a female, you'll have to check, are there more associated symptoms to these urinary incontinence? These associated symptoms, are they more of urological symptoms? For example, I'm talking about the weak urine, frequent nocturia, and so forth. I think if the symptoms are more leaning towards urological problem, I would say refer to urologist. Otherwise, you can refer to urogynecologist. We almost do the same thing, So I think obviously you have to check other things. Is there pelvic organ prolapse? If it's a pelvic organ prolapse, we prefer more of urogynecologist to deal with that. Because that, as it is, it can actually present as urinary incontinence or even urinary retention. So normally what happens is that if a patient comes to me and I feel the patient needs more of urogynecologist, then I'll send the patient to urogynecologist. And if the patient lends to them and they think this needs more of urologist, then the patient will come to me from urogynecologist.
Yeah. No, thanks.
So there's no confusion there.
Yes, Dr. Mulefi, you are okay with that?
No, I think he summarizes very well. Personally, I'd rather have an interstitial cystitis patient treated by a urologist.
Okay. No, that's fine. So there is a question in the box as well by
Before we go to a question, I work with one of physio, Tandi Libete. Can you maybe allow her to say something from physio point of view?
Yes, okay. Just I'll do that immediately after this. Dr. Rabutata is asking, is the efficacy of using autologous Ricard's sheath sling the same as the TVTs and the TOTs? in this instance. It's an 1844 question. So maybe as you respond to that, I will ask Thandi to make a comment as well. Thanks.
So who goes first? Thandi can go first and I'll answer afterwards.
No problem. Okay. Yes, Thandi, you may make your comment if you are there. Yes.
Thank you so much. Can you hear me?
Yes, loud and clear.
All right, perfect. Well, my name is Thandi Lebete. I am the physiotherapist, and like Dr. Mlifi said, I do work with him. This is just advice because I did my postgrad training in pelvic floor health. I hear most physios say it's more of strengthening, but from what we've learned, we actually have to start with the range of motion first, because you notice that there's a lot of patients that you have tension in their pelvic floors, but have the strength, but don't have the movement. So we'd like people to actually start with lengthening the pelvic floor muscles first before strengthening. And we can do this through breathing exercises, like your diaphragmatic breathing exercises, because as you activate your diaphragm, you actually, as your diaphragm descends, your pelvic floor also descends. So actually getting patients to do that working on the coordination, they love when you're strengthening the muscles, because if you do strengthen the muscles without the range, it would be doing more harm than good. So that would be my tip to other physios. And then with regards to our bladder training, we do advise patients to actually, like Dr. Mlifi said, not take your just in case peas, like they should avoid doing that. Instead, that you have timed voids. So if we, for example, we're aiming for 3 hours, but if they can do 2 hours, we can do 2 hours in a few minutes and then have them put it on a timer. And when the time comes, if they feel like they need to pee before the actual timer goes off, then they can do avoiding tactics, like for example, counting down from 107th, or maybe singing or going around instead of going to the toilet, taking a deep breath and contracting as you exhale. That would help a lot. Yeah, that's my 2 cents.
No, thank you. Thank you for that. We appreciate that comment. And I think it's quite helpful. And I think we need to have more collaborative sessions, and hoping that you will join us for more of those. Thanks for that. Colleagues, we are going to stop in the next 5 minutes. If we can just take a few of the questions that people have posted. Dr. Mlifi, I don't know if you are ready to respond to that question by Dr. Rabutata.
I mean, with the slings, I mean, we know that our pubic mid-urethral sling, the outcome cure rate is about above approximately 80% and above. So I'm not sure about the other one, but we know that the sling, they are quite effective in terms of treatment. I haven't looked at the other studies, so let me not lie. I haven't looked at other literature regarding that, but we know that the retropubic sling, 89% cure rate of stress is proven in clinically as well.
No, I think that is cool. What I see, I think most of the questions have been answered. In passing, there was a question about, you've mentioned tibial nerve stimulation as part of your presentation. People are struggling to link the tibial nerve and urinary incontinence. Are you able to say more about that?
Yeah, mainly it's a more of a, so I didn't, on my presentation, I was not more scientific. So there we'll have to understand the physiology of micturition, the pontile micturition center from the sacral nerve. When the bladder is full, what the sacral nerve does, the S2 to S4. So that's where your sacral nerve neuromodulation comes in, your tibial nerve stimulation comes in. So I didn't go into detail regarding that because the whole presentation on its own. So, but mainly just to try to regain, to try to attend to the actual cause, because mainly with an overactive bladder, I've got this constant, when it's described, it's like your heart is like atrial fibrillation of the heart. So we've got a bladder that is in atrial fibrillation. So you want this bladder to listen. So that's why you stimulate the central nervous system using these modalities, so that you can actually try to get control. And it's very, very effective. It's just that patients have to go in and out of theater every 5 years, especially with the sacral neuromodulation, so that we can insert and remove that battery and the stimulation that they put, catheters and all that. It's quite how do you put it? A very important procedure, delicate procedure. So you have to be very experienced to do those type of procedures. So I've seen Dr. Swar doing some of them. I haven't done one myself, but they actually work very well. Patients are happy. The outcome is quite good. So, but basically it's just trying to control the nerves from the central nervous point. From the nervous system point of view.
Yeah, Dr. Morwatse, I see your hand is up. You want to comment on the same?
Yeah, I want to comment on the same, and also on the autologous tissue versus mesh. I think the other doctor actually asked there. So normally with the slings, the mesh, talking about TVT those ones we usually apply them or use them in a patient with normally a simple urinary incontinence, right? We're talking about simple stress urinary incontinence. Whereas if a patient has had previous operations and so forth, that's when now we can use autologous. We can use fascial art, we can use abdominal muscle fascias and all that to actually try to cure this patient. But that one of autologous, we use it in patient that is complex, that mostly has had previous operation. And of course, Dr. Mulif there, just summarized the issue of neuromodulation. Neuromodulation, basically there are two types. There is tibial like emission and sacral. The tibial ones we hardly do. We normally do the sacral one. It's more like a pacemaker of the bladder. So basically trying to put the bladder into its space, So we are putting the muscle of the bladder. We don't really know the mechanism per se. There's so many theories about it. But whoever that came up with it was smart, so because it works. So, but basically just a pacemaker of the bladder. That's it.
Yes, that's innovation in healthcare. There's an interesting question here from Anonymous. It says, if one feels the edge, but only passes drops and has dripping during abdominal exercises, what's your understanding of that, and how do we manage patients with that? I thought I should ask it now, because if it was a male, we might be thinking of other things, but yeah, maybe we can engage on that. So a patient who's got an edge, but they pass drops, and they also have dripping during abdominal exercises. Yeah.
So basically, that patient, by that, you think they're having mixed urinary incontinence. So it's quite complex. So what you need to do with those patients, you need to identify which one is more predominant than the other. So if the symptoms are more towards edge, you have to treat the edge. If it's more towards stress, then you need to treat the stress, because if they've got more edge, then you go put a sling, then the problem will persist. Then the patient will sue you, because you put a mesh and they're not even improving, and you've got a mesh complication. So that's why it's very important to understand what's going on, what is more predominant, the symptoms that are more predominant. So I think that's where your urodynamics comes in, so that you can understand what's going on, especially investigations and so forth.
Great stuff. I'm happy with that. So I think it will be unfair for us to close without talking about nocturia. Someone says, what is the relationship between estrogen and incontinence and nocturia? And he's in the context of bedwetting, so maybe in terms of responding to this, at the high level, how should clinicians approach bedwetting, and maybe what are some of the things they need to be concerned or cautious about in such, because I think it's quite a common presentation. Thanks.
All right, thank you. I don't know if Sydney is still here, because maybe enuresis is more of a urological problem. So
I think he's still
and
here.
then in urogynec setting is one of the risk factors for patients that will actually present with urinary incontinence later in life. So when we are taking history, actually, we should actually elicit whether there was in their childhood at the bedwetting or not, right? So that's more of a urological problem.
Yeah. Okay. No. I think, Doc, we have answered most of the questions. Cypriel, I think your question is answered, that patients who go through procedures. But Dr. Molefi, if a patient goes through a cone biopsy for a high cell lesion, is that a risk factor for urinary incontinence?
No, I don't think there's any relationship between taking a biopsy of the cervix and having urinary incontinence. There shouldn't be any relationship, unless if that patient during that procedure of doing a biopsy, then they injure the bladder by any mistake, because the cervix and the bladder, they are close to each other. So
yes,
and maybe by the way of doing the biopsy, are they doing the biopsy using an energy device? So of which, if it's not in hands that are well trained, they might end up into the bladder and then cause vesicovaginal fistulas and all that.
No. We must appreciate your time. You took such a big topic, tried to squeeze it in less than an hour, and I think you have covered the most important and salient points. So we really want to appreciate you, to appreciate your time. I think, judging by the feedback that we are receiving from the clinicians, everyone seems quite informed. They seemed happy. Obviously, there will always be more and more questions, but yes, we want to appreciate you and thank you for your talk.